I'm Dr. Trevor. So today we are going to talk about disability, coma, and convulsion. So how do we evaluate the conscious level? So we usually use AFPU score. AFPU score A stands for alert. So the child will look around and responsive to the environment. B stands for response to voice. So the children will uh, turns head or opens eyes to mother's call. So it's important to ask the parents to call the patient's name. And then P stands for pain, response to pain. So if the mother calls the children and he or she is still not responsive, we can give some pain stimulus. So by rubbing your knuckles gently on the child's sternum, and the patient will push the hand away. So if after you give the pain stimulus, he or she is still not responsive, it's called U unresponsive. However, for children younger than 2 months old, it's very hard to evaluate AFPU score. So how do we evaluate the conscious level? So we will check the muscle tone, whether the muscle tone is normal, floppy, or rigid. And we will observe to see whether the patient is having any spontaneous movement. So if the patient is unable to feed or hard to settle down, hard to come down, he or she might also be having problem with the disability. So if the AFPU score is V, which is only response to voice, only response to pain, or unresponsive at all, for children older than 28 days, we'll give 5 ml per kilogram of dextrose 10%. And for children younger than 28 days or equals to 28 days, we'll give 2 ml per kilogram of dextrose 10%. So how to prepare dextrose 10%? So because dextrose 50% must not be injected undiluted because they can cause irritation to our veins, and also they can also cause the damage to our brain. So in order to make dextrose 10% from dextrose 50% and dextrose 5% with the ratio of 1:9, which means 1 ml of dextrose 50% to 9 ml of dextrose 5%. So for example, let's say we want to make 100 ml of dextrose 10%. How do we make it? So we use 10 ml of dextrose 50%, add into 90 ml of dextrose 5%. So obviously, you can also use dextrose 10% from dextrose 50% and sterile water. So we need to use sterile water, not just any drinking water. So we can use dextrose 50% and sterile water with the ratio of 1:4, which means 1 ml of dextrose 50% plus 4 ml of sterile water, injection water, because we need to inject this into the vein. We cannot use just any drinking water. So what are the common causes of coma and convulsion in children? Well, the first one is hypoglycemia. That's why we always need to check sugar level if possible. However, if it's impossible to check the sugar level, we need to give dextrose 10% empirically and to observe the response. So the other causes of coma and convulsion in children is fever convulsion. So it's also very important to check the body temperature. If the patient is having fever, we need to reduce the body temperature by using paracetamol by using taffy sponge. And the other cause of coma and convulsion in children is meningitis. And the last one is definitely, most importantly, in Sierra Leone is malaria. So in cerebral malaria, the patient can be presented with fever, unable to eat, change of behavior, change of conscious level, and convulsion. So we need to perform rapid diagnostic test, RDT, or the blood film to check the malaria parasite count. So the treatment for that is artesunate or artemether, as this is the severe malaria, and we'll talk about it later. And you need to treat hypoglycemia, shock anemia, and convulsion it's if present. So for meningitis, usually there will be neck stiffness, photophobia, headache, convulsion, fever, stiffness, bulging in fontanelle. And however, LP stands for lumbar puncture, should not delay treatment. So the treatment for meningitis is still the same, manage ABCD, and then treat hypoglycemia and give antibiotic with ceftriaxone 100 milligram per kilogram once a day, and treat any convulsion if present. So for febrile convulsion, it's a convulsion associated with fever. And short convulsion usually stopping on their own within 5 minutes, and then generalize and recovers completely and rapidly. So we need to manage ABCD and remove the clothes, give paracetamol, and identify the cause of the fever and treat appropriately, and regularly monitor the temperature. So it's very important for us to monitor the temperature closely in febrile convulsion, because fever is the cause of the convulsion. So lastly is the hypoglycemia. So low blood sugar level causes irritability, convulsion, and coma. So it's common in patients with severe acute malnutrition, cerebral malaria, and dehydration. So we need to check the sugar level and consider dextrose 10%. So how do we manage convulsion? So for children aged above 1 month, you can use this flowchart. So let's focus. The first thing we need to do is we need to address the airway, breathing, circulation before treating the convulsion. And we need to check and treat blood sugar, and then treat the convulsion using the flowchart. So the first thing to do is check the time. Note when the convulsion started. And the second thing is SSSS. The first S stands for safe to approach. And then the second S stands for stimulate. We need to stimulate the patient. And then the third S stands for shout for help. And then the last S, consider the setting. So we need to shout for help, call doctor, because it's an emergency sign. So, and then let's focus on A, B, C, D. A is airway. We need to open and maintain the airway by turning the patient into the recovery position. And then B stands for breathing. So we need to give the patient oxygen. C stands for circulation. So it stands for signs of shock, subanemia, malnutrition, and dehydration. So the D stands for disability. So we need to check blood sugar level if available. And then try to put in the IV access if possible. However, if it's very possible, if it's very difficult to put in the IV cannula because the patient is having convulsion, we need to give other medication. Let's say we can give diazepam rectally to stop the convulsion. So we need to put in the IV cannula and then send blood for hemoglobin and malaria RDT, rapid diagnostic test. So if there's no glucometer or the blood glucose level is less than 3 millimoles, then we should give 5 ml per kilogram bolus of dextrose 10%. So for conversion, which is prolonged more than 5 minutes or longer, or multiple conversion, let's say more than two conversion in 2 hours, we need to give anti-conversion medication using the protocol below, and we'll talk about it later. So remember we said that one of the causes of conversion is meningitis, so we need to give IV ceftriaxone and IV artesunate for severe malaria if it's positive for rapid diagnostic test. And then place the patient in the recovery position, and then perform full set of vital signs, including temperature, because we say that fever convulsion is also one of the causes of convulsion. And then ensure the child is receiving appropriate maintenance fluid or feed. So if the patient is having convulsion more than 5 minutes or longer, we can give diazepam rectally if there's no IV access. And then at the same time, we need to try to put in the IV access so that we can give IV diazepam. So after that, we will need to wait for 10 minutes. If the patient is still convulsing after 10 minutes, so we need to give IV diazepam if there's IV access now. And then we wait for another 10 minutes. So if the patient is still convulsing after 10 minutes, which means diazepam is not very useful or not very effective, so we need to give loading dose of phenobarbital. It's either IM or IV, or can also give phenytoin. Depends on which medication you have. So you can see the doses for the anticonvulsant. So for diazepam injection IV is 0.05 mils per kilogram or 0.25 milligram per kilogram. If you want to give diazepam rectally because you don't have any IV access, you can give diazepam rectally with a dosage of 0.1 mil per kilogram. And then you can give phenobarbital loading dose if the patient is still having convulsion after 2 doses of diazepam. So the loading dose for phenobarbital is 15 milligram per kilogram. It's either IV or IM over 15 minutes. And you can also see the maintenance dose for phenobarbital. So for phenytoin, an injection is 15 milligram per kilogram over 1 hour. So it's important to focus on treating hypoglycemia before treating the convulsion. So make sure you give dextrose 10% empirically if glucometer is not available. So these are the doses and the table you can use for dextrose 10% and for IV diluted diazepam and IV undiluted diazepam. So for diluted diazepam, we use 10 milligram of diazepam in 10 mils of solution. And with IV undiluted diazepam, it's 10 milligram in 2 mils of solution. And you can also see the dosage of rectal diazepam is 10 milligram in 2 mils of solution with the dose of 0.5 milligram per kilogram. And remember, we say that the rectal diazepam you can also use 0.1 mil per kilogram. And so these are the table. So you can use the body weight to find the solution, the concentration and the solution you need to use for the conversion. And you can also see how to prepare diluted diazepam. So diazepam 10 milligram 2 mils is diluted with 8 mils of injection water to make 10 milligram in 10 mils of solution for diluted diazepam. And then this is also the loading dose for phenobarbital and the maintenance dose for phenobarbital according to the body weight. You can also use phenytoin if it's available. So because malaria is one of the most common causes of convulsion and coma in Sierra Leone, now we are going to talk about malaria for a little bit. So first of all, what causes malaria? A. Plasmodium falciparum. B. Plasmodium vivax. C. Plasmodium ovale. D. Plasmodium malariae. And E. Plasmodium knowlesi. F. All of the above. Yes, all of the above Plasmodium falciparum, vivax, ovale, malaria, and knowlesi can cause malaria. But in Sierra Leone, most common cause of malaria is Plasmodium falciparum, which accounts for 90%. So 10% of the malaria is caused by Plasmodium ovale. And how is the malaria transmitted? It's transmitted by mosquito. So these are the treatment guidelines for malaria. So first of all, if the body temperature is higher or equals to 38 degrees Celsius, or history of fever in within 48 hours, we need to test for malaria. So we can use RDT, which stands for Malaria Rapid Diagnostic Test. And we can also use MPS, which is Malaria Parasite Count, to test for malaria. So if RDT or Malaria Parasite Count is positive, the next question we need to ask is whether this patient is having severe malaria. So what is the definition of severe malaria? So the first definition is more than or equals to 2 convulsions in 24 hours. And prostration, the patient is not able to walk or sit without support, or unable to drink or breastfeed. And then the third criteria is increased work of breathing when pneumonia is unlikely. Let's say the patient is not having cough, there's no sputum. However, the patient is breathing very fast. And then the fourth criteria is hemoglobin less than or equals to 5.0 gram per deciliter, or shock. Remember we mentioned about the criteria of shock in children, cold extremity, capillary refilling time longer than 3 seconds, and weak and fast pulse. And then the other criteria for severe malaria is alter consciousness. So conscious change is also considered severe malaria. And also blood sugar lower or equals to 3 millimole per liter is also the criteria for severe malaria. So we need to ask this question. We need to test for hemoglobin, and we need to test for sugar in every patient who is diagnosed with malaria to screen for severe malaria, because the treatment is different for severe malaria and uncomplicated malaria. So as you can see, this is the treatment for malaria. So if the patient doesn't fit any criteria for severe malaria, it's uncomplicated malaria. The treatment for that is artemether lumefantrine tablet BD for 3 days. And if the patient is having severe malaria, there are different types of medication we can use. So the first type of medication we can use is injection or IV or IM attachment. So the dose for IV attachment, if the body weight is less than 20 kilogram, is 3 milligram per kilogram. If the body weight is more than 20 kilogram, is 2.4 milligram per kilogram. So the concentration will times body weight and then divided by 10 is the amount of meals we need to give at 0, 12, and 24 hours. So other than artesunate, we can also use artemeter IM. So for the first dose, which is given at 0 hour, is 3.2 milligram per kilogram. And then the second dose for artemeter is after 24 hours, is 1.6 milligram per kilogram, which is half of the first dose. If the patient is vomiting and he or she couldn't swallow the medication, he or she couldn't swallow the tablet, we need to continue the injection drugs once daily for 6 days. So it's important to evaluate whether the patient is having any vomiting after 24 hours. If there's no vomiting, we can switch to tablet artemether lumefantrine and continue the tablet treatment for 3 days. So the last thing we need to know about malaria is in Plasmodium vivax and Plasmodium ovale, sometimes malaria, the parasite will be hidden inside the liver cell and then become activated again, which is called relapse. So in order to prevent relapse in Plasmodium vivax and Plasmodium ovale, we need to add primaquine, 30 milligram OD for vivax and 50 milligrams OD for ovale for 7 to 14 days, according to the local guidelines. However, because we need to be careful if the patient is having G6PD, because primaquine can induce hemolysis in the patients with G6PD. Thank you.